So I'm going to take you through low-level light therapy and hair loss. How many scientists do we have in the audience? How many doctors or nurses, clinicians? Okay, so get an idea. Okay, so from the University of Minnesota, my institution has received devices on for that what I'm about to present to you. This is my first 10 years out in academic medicine. So let's talk about photobiomodulation. Photobiomodulation is also known as low-level laser therapy. You can either use laser diodes or LEDs, light-emitting diodes. So it can also be referred to as low-level light therapy. Most devices are at 650 to 655 nanometers. You can find combined devices. You can find devices in the 800s that are being investigated. And the devices were FDA cleared initially in 2007, and the studies were actually really good. So I'm not going to go into that, but there is solid efficacy data, randomized controlled studies where hair counts were performed, which is what the hair expert world really idealizes as a gold standard. And also of note, our JAD 2024, that's the journal that the dermatologists look at as their primary journal, photobiomodulation is noted to be this month's CME article. So clinical pearls. You can refer your patients to get photobiomodulation or low-level laser light. They typically need to have a budget of around $300 to up over $3,000 depending on how the device is designed. Each device can deliver a different amount of energy, and the number of lasers doesn't necessarily mean that the device is better, or the number of diodes. What matters is what energy is being delivered to each section of the scalp, more likely. Your patient can get a band, they can get a comb. It's FDA cleared for men and women, as I mentioned, for over a decade now. In our new JAD CME article, I kind of updated what you can see my mouse here, what my fellows had made, but this is the mitochondrial membrane space, and this is red light, maybe some infrared spectrum, and it hits cytochrome C4, and then somehow there's an increase in ATP, nitric oxide, and calcium. And it's thought that that also stimulates ATP, NF-kappa beta, and growth factors, and then hair growth. And I would really say the calcium and the ATP, that's part of the CME update from the JAD. You can also use these in office. So that means the patient comes in and then you give them light. Maybe they're waiting for their platelet-rich plasma or some other treatment, and they sit underneath the light. And then sometimes, because it's a non-hormonal way to grow hair in patients, in our more gender diverse population where our patients might be on hormones, they may be trying to feminize, they may be trying to masculinize, low-level laser light is that non-medical option. So people always ask me, which device is the best? So we ended up doing a blinded study where we brought the patients in 3 times a week for about 3 months to see which devices worked the best. And we were blinded, and at the top you can see before in a patient, I'm not even sure which device they were on because I'm blinded. And then the bottom, and you could see their hair parts tighten and the width tighten. And then we recorded, now this study started like 6 years ago, before we had hair counts and artificial intelligence. So we used Hamilton-Norwood scores for male, and each line was a male that actually completed the study. Keep in mind they would come 3 times a week to our institution to do it. So it's a small study number, but you could see their scores slope down. Most of the patients improve and the numbers go down. For women, we would use the Savin score and the numbers generally sloping down, or the Ludwig score, okay? And you could see generally improvement, 1 patient worsening. So when we blinded ourselves, board-certified dermatologists, to the images and graded them, we found that men in office, the laser comb, and even the LED helmet all performed well. Females, we found the laser comb and the in-office performing well. So both groups, the laser comb performing well. And the laser band wasn't statistically significant in each group, but we did have a small sample size. The laser band we used is marketed at 90 seconds. So I'm not sure if that was my small sample size or if it was the energy delivered isn't enough to grow hair. And then the combination laser LED helmet, also not quite performing as well in this study. Men were more likely to report hair growth. Older subjects less likely to see hair growth. Maybe their disease was further along, and there was just no statistically significant difference in satisfaction. However, if you interview patients in a hair loss clinic, if you have them fill out a survey in a hair specialty clinic, they say they're willing to wait 6 months to grow hair. You could see here in one of our posters that patients felt satisfied with the comb or the helmet or the laser band, okay? So this is asking patients, and it was sort of like an equal distribution, essentially. Then we thought, well, let's do an online study. Let's send out to Facebook and see what patients say about what these devices and which ones they think work and whatnot. So we sent out to support groups, to the National Alopecia Areata Foundation, the Scarring Alopecia Foundation, and they had to be 18 or older with hair loss and interested in using a photobiomodulation device. Most of the people who responded were women, half of them were white, and most of them were sort of middle-aged. Most of them felt that they had a diagnosis of complete hair loss, okay? A small proportion felt they had generalized thinning or a receding hairline, and they felt in these Facebook groups that knowing that these devices are efficacious is the most important thing when they picked a device. So I'm sort of telling you a story here. Telling your patient that the device does have data, that it is efficacious could be helpful, and most of them say it's regardless of price and that they might prefer a hands-free device. What is the safety profile of these devices? Well, generally, they're really extremely safe. Some patients feel it tingles or it's a little itchy. In that androgenetic alopecia population, you want to avoid shining it in their eyes because it's a laser, and then they can experience an initial shedding. And then we presented at ASLMS last year some patients in our study developing headaches. So we had 4 cases of headaches that we had to report to our IRB with these patients coming in, all with a diagnosis of androgenetic alopecia. 2 of them withdrew, 2 ended up completed. We had a few ER visits. All the headaches terminated. So maybe if your patient has a history of severe headaches, this might not be the first thing that you would pick. So we notified the IRB, we contacted the device companies, and they had said that they'd heard this, but it wasn't to the point where it required any sort of notification. So just make sure they don't have a big headache history. So when you're picking which one to recommend, is it affordable? Combs are cheaper, less diodes, less light is in it. So it's smaller and they have to move it over their scalp, but they have to use their hands. Helmets and caps are more expensive. There's more, actual product going into making the device, and you can just put it on and do something else. Is the hair thick? You might prefer something that has teeth or pegs so that your patient can get through down to their scalp. And then patients with extensive hair loss may find caps and helmets more helpful because they're trying to treat their whole scalp globally. But if there's a lot of hair loss at the front of the scalp, that could be difficult because sometimes the caps and helmets don't cover that frontal part of the scalp. And actually the combs in those unique areas could be more helpful. Very quickly here, we're going to run through our less common causes of hair loss. Everything I've talked about so far, I'm talking about androgenetic alopecia. Telogen effluvium, we have a study here in the Laser and Surgery Medicine Journal. It was 32 weeks. It was a 655 helmet. No significant difference with TE patients. I would say too preliminary to make a conclusion on telogen effluvium. Just one study. I would not conclude that it didn't work at this point. Scarring alopecia, 2 big key studies, primarily in the JAD, where we see a decrease in that investigator score for lichen planopilaris. That's a score, the lichen planopilaris activity index. We want to see that drop, okay? At 6 months, we see a drop with this LED device in this case series, and we see that replicated again in this case series. So it seems like it is probably helpful. And then this update in 2023, where we start to venture into CCCA, which is the scarring hair loss disease, primarily on the top, a case series with a combination helmet by Dr. McMichael. We have an increased hair density over 6 months. These patients were on their usual hair care regimen, but they did have improvement. Nothing harmful was seen, and we could see improvement with these patients in this case series. Again, all of this is at the case series level. And when you combine it, I would say there's not data necessarily for scarring. It's not clear whether or not putting them together with minoxidil makes it work better. I would say generally my conclusion from reading is combining them is not likely harmful, and it may be helpful. Like you have nothing to lose, essentially. So in this review, 5 randomized studies, no difference or some improvement what if you start minoxidil and you start the light during the study and there's a shed from the minoxidil right at the beginning? And then usually there's a little shed sometimes from the laser comb. So these studies can be very difficult because when you stimulate hair growth quickly, you typically see a shed. In our hands and scarring alopecia, we see clinical improvements. In our retrospective study, they did not reach clinical significance with photobiomodulation, but this is real world chart review, right? So not as tight as what we could do with hair counts. And then just breaking down into combination treatments, I wanted to just pull up some of these key studies just so you guys are aware of them. Some of them using half scalp design, which is difficult in the hair loss world because the minoxidil or the light could affect the other part of the scalp. And then I wanted to point out in those combination studies, 2% minoxidil was utilized. So again, making it hard because most of us are using 5%. So future directions, I think the role in gender affirming care is really interesting, like we talked about, and that's a direction that I'm sort of investigating now. I've expanded into these devices are FDA cleared for Fitzpatrick skin types 1 through 4, not 5 through 6 in those early 2000 studies. So we took that a step forward. We enrolled a handful of patients with a darker skin type to see if there was going to be any side effects. And we saw improvement in 4, no change in 3, worsening in 2. But the patients, 4 of them were satisfied. Some of them would recommend it. And you could see the breakdown in this darker skin type population. Mostly androgenetic alopecia. We did have one combined AGA, LPP case, and at the bottom, one CCC case that was willing to come in. One of our androgenetic alopecia cases here, we were completely blinded to which device, but you could see improvement with photobiomodulation therapy. My final 3 slides on this topic. There are 3 light-based treatments that are now really emerging as technologies where I would say our clinical use as dermatologists and other types of physicians in this area will emerge over the next 5 years. This is an FDA Class 1 device that's an ultrasound technology that delivers acoustic waves. But the data depends on a delivery of proprietary product. That always makes me wonder if the device is worth it, if the device is necessary to achieve the effect. No downtime, no anesthesia, and 30 minutes is what is sort of touted about that product. The second is a microchannel laser technology, a non-ablative thulium laser with microchannels that help with product absorption. This requires a nanoliposome uptake. So again, dependent on a proprietary product in combination with the technology. Some warmth, 6 session with improvement after a period of 3 months. Finally, the newest device, which was just FDA cleared, which is an actual laser creating tissue coagulation and hair stimulation. This is Dr. Abrams' study, which I think he'll be publishing. 3 to 6 treatment sessions, 4-week intervals, up to 30-minute procedure, no anesthesia, minimal discomfort, not dependent on drug delivery. So I think this is just the tip of the iceberg when you're starting to see new devices come out. So I would say generally we have this new darker skin data. It seems like it's safe to utilize in darker skin types without an issue. More studies to confirm efficacy on that. And it'll be interesting for us to all get our hands on these newer devices and present more data on that. So thank you so much for listening to me. This is my photobiomodulation team.